everybody. Thank you so much for being here today. In my opinion, one of the most exciting parts of this conference is getting to talk to people on all different sectors of the healthcare industry. So we have providers, payers, nonprofits, everybody in between. And this is going to be a really exciting panel where everybody's going to be able to take a look at one very crucial problem, how mental health connects to physical health, and show you their perspective. So the way this is going to work is each of the panelists will do a short presentation, and then we'll have a moderated discussion. Reena, take it away.
Thank you. I'm your lead-off hitter today, and we'll share a few thoughts, and then I'll pass the baton to the other speakers, and then we'll, as Leah said, we'll have the chance to talk amongst ourselves and share more perspectives on the connection between mental and physical health. But just by way of introduction, my name is Reena Pande. I am the Chief Medical Officer at a company called AbleTo, which seems like a perfectly apt name in this room of change makers. I am actually a cardiologist by background, and so you might scratch your head a little bit and wonder how a cardiologist got to focusing on mental health. And for me, it was having spent many years in academic medicine. I did all my training in Boston, which is where I still live. Came to the realization that, boy, we spend a lot of time trying to inspire and motivate our patients to make change. In cardiology, making changes to diet and nutrition and smoking habits is central. I mean, 70 or 80% of the risk of cardiovascular disease is related to these things we have the power to change. And yet, it's so hard for our patients to make those changes. And what I came to realize a little late, I'll admit, is the degree to which we don't really, as physicians, think about what barriers are keeping our patients from making those changes that we and they know are in their best self-interest and will impact their outcomes. And then it came a little later in the game, and my understanding, the recognition that for so many of my patients, mental health was that barrier. And that we did such a poor job, even at a Harvard teaching hospital, to be honest, at identifying that need and being able to direct our patients to high quality mental health care solutions. And it really was central and foundational and frankly a prerequisite. And I think if we don't do better at tackling that mental health comorbidity for our patients with physical health conditions, boy, are we losing an opportunity to really help them make the changes in behavior and other outcomes that we seek. So a couple of statistics, and you'll see in our three presentations the numbers are pretty close, maybe not exactly the same, and they come from very similar sources, but the concepts are the same. We have a lot of patients suffering with mental health conditions. You can see in the top right, at least 1 in 4. Some studies would say even more than that. And in the top left, so many people are suffering and are not receiving the care that they need and deserve. So a lot of undiagnosed patients, and a lot of those are going untreated as a result. For me as a cardiologist, the bottom left was what brought me to this work, this realization that, oh my goodness, at least 1 in 4, maybe studies would say even more than that, of my patients with medical conditions, and I came to it from a cardiovascular perspective, but you could substitute diabetes, chronic pain, what have you, a rheumatologic condition like rheumatoid arthritis, you name it. And that statistic will be basically the same, that at least 1 in 4 of our patients with physical health ailments are also suffering from depression or anxiety, and a lot of the time that's going untreated. What was really interesting to dig into the data was to discover that when the two go together, a physical health condition and a mental health condition, the total cost of care is 2, 3, 4 times greater than if you had heart disease or diabetes or chronic pain without depression or anxiety. So a real opportunity to help patients get better. And as you see on the bottom right there, the main number here, the main point here is that number starts with a B, billions of dollars of cost to the healthcare system and lost productivity if you account for the impact to employers. So I started this work 2013 was when I kind of realized that there was more to be done and that we needed to think about integrating physical and mental health, that we needed to think about how to use technology to get better access to mental health services for our patients in need. So 2013 is not even on this figure. So when I started with AbleTo, the chatter about mental health in these circles was probably high, but out in the rest of the community was just barely a whisper. We would show up at a health plan to make the pitch that they should work with us, and it was like, we've got that, thank you. It's only 3 or 4% of our budget, so we're not really paying attention to that. And the message that we had to send was, hey, by not spending money on mental health, you're actually spending a whole lot of money on mental health. And that was the change in the conversation that we were trying to make, the educating we were trying to do. And what's been really neat is to watch that people, consumers, all of us are starting to really think about mental health. This is sort of a fun trick. You can go to Google Trends, type in whatever you want, and see the frequency of searches in Google for a particular topic or subject, and this is what we did. And so if you look for mental health services near me, you see this sharp increase. So people are thinking about this. That quote on the top right I thought was super interesting. Mental health related books outsell diet and exercise books for the first time at Barnes & Noble's in the LA Times last year. Interesting, really interesting. This is a focus. Just clipped a couple of headlines, whether it's the New York Times or, I should have had Forbes for you, Leah, but I don't have there is plenty of stuff in Forbes too, or LA Times. This is top of mind, which is great. Now the problem is that consumers, patients, we people are thinking about this, but access has not kept up. This is just a figure pulled from a paper published a couple of years ago. This is psychologists, it could be psychiatrists, it could be nurse practitioners. The figure looks the same. There's not enough access to care. I won't go through all the stats, but we have a problem, and it's a problem that we need to figure out how to solve. And so what has happened is that this has happened. So you guys may realize, and maybe hearing, and maybe even seeing commercials for all these technology-enabled and digital solutions to try to meet that need. An app for this, an app for that, a platform for this. And it is extremely confusing for folks like Cary, who sits on the health plan side, a bombardment of these potential solutions. How do you start to tease out what's right for a patient? How do we direct patients to the right solutions that meet their clinical need, but at the same time, the right modality of engaging with them? My company, is one little logo on this slide, AbleTo, in the telehealth bucket at the top right. We tackled this solution by providing virtual access to licensed mental health clinicians, enabled by a technology platform. And then also an app, so a more intense intervention and then a lighter intervention to help meet a patient where that patient is in terms of the severity of their condition and the modality by which they're most likely to engage. But the challenge that we've seen, it used to be that we would have been the only one on this slide 6 or 7 or 8 years ago. And now there's this explosion of solutions, all claiming to increase access. Many have clinical merit. But what we need to be thinking about next is not just access to solutions, but access to high quality solutions. And I think that's going to be the next thing that we in the mental health space and in integrating mental and physical health focus on, is how do we make sure the care that's being delivered is actually of high quality, that's clinically sound, and not just opens up access. And because if we can marry access to quality, that's when we can really see results. So in the last minute, let me just tell you a little bit about the work we've done and the successes we've seen in thinking about this integrated approach to mental health care and physical health care. So we have a national network of about 700 licensed professionals that are delivering our evidence-based programs via our technology platform or just by the plain old telephone, if that's the easiest way for you, a little more anonymously, to engage with our providers. And when they can do a cognitive behavioral therapy program in that fashion that's very quality assured, clinicians are all supervised, we're making sure they're actually adhering with fidelity to the clinical protocols. You can see the kind of outcomes that we're showing on this slide. Mental health symptoms get better, depression, anxiety, stress. And the real thesis was by tackling mental health, can we have an impact on physical health outcomes? And we've spent a lot of time focused on measurement-based care and proving that that thesis is actually true. That if you can tackle someone's depression, actually, they're going to be more likely to test their blood sugars. Fasting morning blood sugars will go down. Smoking cessation is improved. Adherence to medications is better. Pain scores are lessened. And the last real thing to cinch it all together is that top right, which is that if you can do that, you can make the pitch that there's a real financial argument to doing so. So patients get better, and that you can keep them out of the hospital and save money for our payer friends. It's a win-win for everybody. So for me as cardiologist coming to this work, it's been so fun to be an agent of change like all of you and preach the message that we really have to think holistically about integrating physical health with mental health to really have the greatest impact that we can. So thank you.
Thank you. That was excellent. I appreciate it. Good morning. My name's Tyler Norris, and I am the CEO of Wellbeing Trust. We're the nation's leading philanthropy focused on advancing the mental, social, and spiritual health of the country. And I stand before you as a leader in the field, but it wasn't always that way. When I was 14, struggling with mental health and addiction issues, I found myself face-to-face with the criminal justice system. And instead of being folded into the system, community saved my life. I was diverted. I was given an opportunity for reconciliation and restitution. And I was folded back into the community where I could heal. And for the 40 years since, I've dedicated my life to building communities that are gardens to grow people in. Now, that's meant working in hundreds of communities around the country, and it's meant working on partnerships to build the kind of systems and policy changes that can result in the health of populations. Recently, my daughter, who's very sharp and is kind of all over these kinds of issues, said, "Dad, I've been looking at recent data that said after a century of increasing lifespans, in the last 2 years, Americans' lifespan has been shortening. After everything you've been doing, what have you been up to?" Yeah, it's kind of funny and really scary. Because on our watch, despite all the technology, the trillions of dollars that are being spent, we're going the wrong direction, mostly driven by the deaths of despair. When our foundation was launched 3.5 years ago, the first thing I did was we partnered with the Robert Wood Johnson Foundation and Trust for America's Health to look at the work of Angus Deaton and Jean Case on what is going on underneath deaths by alcohol, opioids, and suicide. Suicide rates that are tripling for young women at ages 11 to 14, and white guys my age, the tripling rates. Everything else doubling rates in the last decade and slated to double again. And what we needed to do was unpack that and go, what is underneath that? The hopelessness, the loneliness, the isolation, the lack of belonging. What is going on such that that is how we're dying? So that we can get at the actual root causes. I won't spend a lot of time on this side because you just talked about this. 39% of admissions comorbid, right? And I'm just going to say that I don't even think it's 1 in 4, 1 in 5. I think that's useful language at one level. It's every single one of us is either directly struggling with a mental health or addiction issue or somebody we love is. Every single one of us. So when we're looking at this, we're asking the question, well, what is it going to take not to just save a life or two, as important as that might be, but how do we turn the tide on the deaths of despair? What kind of a response is needed from our nation and from the trillions that we're spending to actually have a population-level outcome that my daughter would look at and say, now you're talking, Dad, instead of messing around. You're doing good things, but are you accountable for outcomes, right? That's the question. So we have to say, the loneliness, the isolation, yes, but what about the fragmented delivery system where only 1 in 10 people actually gets the substance misuse care that they're actually needed, and most visits don't integrate mental and behavioral health with physical. And then the conditions in communities that were discussed earlier, where racism and lack of access to living wage jobs and housing and food insecurity are all conspiring. So how do you really take this? Now, one of the interesting pieces around adverse child events, which is talking about our adverse community experience, the parabases, is that when you think about this, particularly this intersection between mental health and physical activity, most of the things that all of us do to deal with the trauma and the early life things we're facing, those are our attempted solutions that are driving our poor health outcomes. Look at Dr. Folletti's point, that most of the problems we're facing are our solutions to deal with what we are facing, shrouded by shame and secrecy, etc. So, for example, making the link with physical activity, let's get into nature. We found that when you, in fact, are in nature and physically active, that prosocial behavior, a sense of belonging, awe, and wonder, a sense of things that are actually improving our mental health actually improve. When I was at Kaiser Permanente, and there's some colleagues of mine in the room here from KP, we focused on walking. Why? Because physical activity, particularly if you're doing it with another person or in nature, is good for your mental, emotional health. Being in nature, conviviality, human connection, that adds up. But it wasn't just enough to have the behavior change of walking. We need to create safe spaces. So we partnered with Girl Trek. Now over 1 million black women and girls walking, not just getting their physical activity, empowerment, belonging, leadership, taking back their communities. Vision Zero, making it safer to design communities where walking and biking is easier and safer. Complete Streets, making streets that routinely accommodate physical activity so that more people can be physically active and has mental health benefits. But if you really look at what's underneath this, what is this mix of forces behind the deaths of despair? It isn't going to just take clinical changes and changes in our policies and practices and building partnerships. It's going to take a new way of thinking and a new way of acting about mental health. So our foundation is the leading philanthropy right now, bringing policy leaders together, bringing philanthropy together, is committed to saving 100,000 lives over the next decade through a social movement approach. So what we're looking at right now, and you're welcome to see this, I'm adding it so you can look at it later if you wish, is a framework for excellence that is capable of a population-level outcome on mental health rooted in changing community conditions, assuring everyone has coverage for accessing services, and that there is no wrong door, whether that's the health system, one's school, one's workplace, or the criminal justice system. The largest provider of mental health services in the state of California is the LA County Jail, right? So let's think about where the actions are. Our priorities are 3. Get the care right, get it paid for, and create the conditions for mental health and well-being in the first place. And great care, as was talked about, is not only integrating physical and behavioral health, it's integrating social needs. If you don't ask about food insecurity and housing insecurity or domestic violence and address that, you're not going to actually change someone's behavior. It's not going to work. It doesn't work. You have to integrate physical, behavioral health, and social needs. That's quality. Anything short of that doesn't add up. Secondly, we need to drive federal policy to pay for it and create these gardens to grow people in. So we're committed right now to a social movement, new narratives that make it safe and reasonable to talk about our mental health issues. Pull the stigma out, normalize the conversation. It's all of us. We share in our suffering, whether it's our own or each other. Secondly, metrics and data systems like we've done with WIN measures, winmeasures.org, new measures that are being adopted in this country through the National Committee on Vital Health Statistics, looking at a well-being adjusted life year, not just a disability adjusted life year. What does it mean to live healthier lungs? Standards of care excellence that I'm saying that says standard quality care, behavioral health, physical health, and social needs, warm handoff referrals, right? If you know that your current model of care isn't adding up to population-level outcomes, it is unethical to continue behaving that way. Policy and advocacy. Good federal policy, good state policy, and advocacy organizations to drive it. Bringing more money into the field. Only 3% of philanthropy is dedicated to mental health, and yet it's killing 170,000 of us a year. So last week, we released federal policy on Capitol Hill under Healing the Nation on what federal policy needs to look like for integrated whole person care with no wrong door. We are partnering with dozens of NGOs across the country on transportation, on housing, on early childhood development, first 1,000 days, living wage jobs, because we know that communities are what gives rise to mental health in the first place. And what we're seeing right now, which is so exciting, is that it is not just all the apps and technologies and new forms of care that are important. Those are vital. But it is the way this nation is beginning to rise to say that we cannot go on the way we have. We are in this together, and our nation depends on our mental health and well-being. There is no health without mental health. Thank you. Cary.
Great job. Well, good morning, everybody, and thank you for having me here. I represent the plan side. I, by my previous history, am a board-certified family physician. Practiced and decided that working with managed care was very difficult. I thought there was a better way to provide care. From that time, I've been working with most of the nationals, Aetna, Anthem, Pacificare, Humana, and right now I serve as Chief Medical Officer and Vice President for Sharp Health Plan. Just to level set so you know where my conversation is coming from today, Sharp is the largest integrated delivery system in San Diego. It is the highest market share of any plan or any integrated system within California. We have the whole continuum of care. We have acute care hospitals, we have specialty hospitals, which include behavioral health and substance abuse. We have our medical groups, we have outpatient clinics, the list goes on and on. Suffice to say, every part of care that needs to be provided to our members is provided by us. Also, as part of the health plan, we have about 150,000 members as part of our plan. So that gives you a little bit of background on, who we are and what we do. But at the end of the day, what are the results? Because if you don't look at healthcare differently, especially related to the great people that are making a difference moving forward in healthcare in terms of combining and treating patients more holistically, you don't get these kind of results. We have one of the top-rated health plans in the country, 4.5 stars. Medicare, 4.5 stars. California has the most sophisticated health plans in the country. I think many of you would agree. And yet, with that being said, for the last 5 years in a row, we've been seen by our members throughout the state that we are rated the highest in terms of member experience. So there's a there, and I want to give you a little view as to what that is. But first, from my perspective, as somebody that is involved in trying to keep patients healthy or get them healthy, what am I dealing with? What is the problem that I'm trying to solve for? And that is value. If you look at healthcare today in the United States versus other parts of the world, the sentinel measure for healthcare quality is life expectancy. This is very distressing, and it's been stated here already that we're not doing a real good job. Compared to other industrialized countries, you can see that life expectancy is not as good in America as it is in these other places. To compound that, look at how much we charge. The cost per capita is 2 to 3 times more to get these kind of results. And as it was stated already, if you look at the tail that goes on from 2014 to today, you see that there's actually a decline in life expectancy. What does that mean for you and I? That means that our children and our children's children will be the first generation in decades that will live shorter lives than we will. That cannot happen. We cannot allow that. We have to do more. So let me give you what we have developed as a solution to this problem and what we have implemented over the years. This idea of population health. Everybody talks about it's kind of the flavor of the month, but there's a difference between actually doing it to the full extent possible and to nibble around the edges of it. So everybody has a different definition of what pop health is and what it actually means. For me, it's a very simple definition. It is that we have the ability to analyze big data of a population to be able to manage the individuals of that population. And this is done, and our model is designed to manage our patients holistically. What does that mean? It's not siloed into medical, behavioral health, pharmacy, as it was in years gone by, but it's actually integrated together. And it's built on the 4 premises of improve the patient experience, and that you saw our results, decrease costs, improve healthcare outcomes, and also enhance the physician experience. So that's the quadruple aim, those of you that know about that. So one of my questions is, why do this? I'm asked it all the time. So let's just look at it strictly by the numbers. If you look at it, 40% of patients that go into the primary care's offices, they have behavioral health issues, they have mental illness. 27% will have a substance abuse issue. Over 30%, and the statistics go anywhere from 29 to 60 on this, but say it's 29% of patients that have chronic disease, medical chronic disease, diabetes, heart failure, and so forth, will have underlying behavioral health issues. And what is the most telling of these statistics is the last one. 67% of members with behavioral health disorders do not receive the care that they need. So this is the problem that we have by the numbers. So is there a value proposition? Because you know I work for a health plan, and we only do things where there's value involved. Actually, the studies are showing that there is value in this, substantial value. You've heard some of it already. There's increased access, there's improved outcomes, there's improved compliance, and also decrease in terms of total cost. That is a proposition that you can't stay on the sidelines for. So let me give you a brief view into Sharp Health Plan's population health model. Now, usually it takes me an hour to just talk about one of these things, and could take a whole semester to talk about all of them, but I'm going to try to do it really quick for you right now. First, we start out with data integration. We have a data warehouse which is unified for all of our organizations. Claims, clinical, as well as administrative data all comes in. Then we look at analyzing all of this big data with a predictive modeling tool, so that way we're able to segment our population into these various categories throughout the continuum of health, both on the physical as well as the behavioral health side. For each one of these, there's programs, services, and results. And then we stratify these members, not only to the risk today, but what it's expected to be in the next 12 to 24 months. We take that robust data, information, and reporting and provide it to the providers that are caring for our members. And you can see that the members are in the middle of the care. It's actually the members and their families that are in the middle of their care. Then we wrap around collaborative efforts and targeted approaches to help our members. We then also have safety initiatives which affect all of our members, and then look to have advanced access opportunities for them also. But then we have to see what we did, does it mean anything? Are we making a difference? And in fact, that's what we do, is reporting back to determine, are we making a difference? Are we actually improving care for our members? And then we make tweaks or wholesale changes to our system to continue to improve, because healthcare is a dynamic, right? You never step in the same river twice. And then lastly, component that is truly important, and I think critical, is that of value-based reimbursement. The idea of fee-for-service is not connected at all with anything related to quality. That needs to change in America today. So let me talk to you really quick about, call out two specific issues related to healthcare and our model. One is the impact of social determinants. You've heard it before. I know that that's a big issue, but how much of the care that we deliver improves the total health of our members? I know you wouldn't find it surprising to see that it's only 20%. Actually, 80% is related to the social determinants. That is related to health behaviors, that's related to socioeconomic insecurities, as well as housing. I could talk to you for a long time on the statistics and the studies that have come out to show the value in addressing these needs. But let me just take housing as a premise for this. If you look at the life expectancy that I showed you before, in the United States, it's 79 years. But then if you go ahead and look at those that are chronically homeless, it's only 64 years of age. Again, you could see statistics like this across the board. Next, I just want to leave you with the idea of increasing access. We live in a day and an age of 2020 where people don't want to get their care anymore in a big, beautiful building with the best doctors and providers and beautiful artwork and landscaping. What they want is care when they want it, where they want it, for the conditions that they have, and for the severity of their problems. I kind of break that up into three components, one being the on-site care, which is your bricks and mortar, right? It's your primary care and specialty, your hospitals, your urgent care, and so forth. And then you have the near-site care, and that's related to your worksite wellness programs, we have relationships with MidaClinic, with CVS, and your pharmacy partners where they can help to educate and provide care. But the biggest area of opportunity is that of telehealth. Now that is a big area. It's not just talking about text and online visits and emails, but it's also remote monitoring and expanded home health and digital member management, and it's also AI. AI is critically important also. So just in closing, we are committed to best-in-class behavioral health integrated strategy. Those are the 5 principles that I believe you have to have if you're going to have a truly integrated system between behavioral, medical, and pharmacy.
Thank you so much.
Thank you. Bye-bye.
Well, thank you guys all so much. Those were fascinating presentations, and I'm really excited to start the discussion portion of this panel. I'm going to start with you, Reena. You guys recently released a very interesting study, partnership with Humana, about cardiac failure and patients and how that relates to mental health. Can you tell me about some of the results you found?
Yeah, absolutely. Of course, close to my heart as a cardiologist. No pun intended. Really, truly, no pun intended. You know, they had at the executive level a push to tackle patients with heart failure. So that was really at the top, and they recognized that mental health was an element of that, and that by addressing mental health, perhaps they could have an impact on their heart failure population. So this was a health plan leadership decision that they wanted to do something proactive and innovative. And so we partnered with them to deliver our clinical care, cognitive behavioral therapy for their heart failure members. Actually, we baked in an assessment of heart failure self-care, and what we found was that those heart failure patients who went through our program actually had significantly improved ability to do heart failure self-care, so monitoring their diet, monitoring their weight, adhering to their physician's recommendations. So a really nice example, a really nice case study of this ability to integrate physical and mental health and see a real impact on the physical health side.
Yeah, so interesting. And a lot of you guys talked about access to care and how that can be really difficult. And I mean, as you all know, especially in rural communities, and in communities where there's a lot of stigma around mental health, that can be even more challenging. Tyler, do you think telemedicine in mental health is a solution?
I think it's a partial solution, but I think we need to really look at what the challenge is with the access issue. First of all, and Cary pointed it out, 2/3 of Americans don't have meaningful access to a mental health provider, even if they have a health plan. So you find out, you get coverage, and you try and get to the panel, and you start calling around, and they're out of business, and they're not taking on new people. So I think the first thing we need to understand is that the current forms of coverage and mental health parity, which is the law of the land, is not being enforced and not adding up. So this is the first thing, even if you're covered. So yes, telehealth, it's powerful. I think we've seen it work beautifully well. But I think we need to be careful of fixating on telehealth alone as if that's it. I mean, I'm interested in other models. For example, Dr. Elizabeth Markle's on a panel later today talking about community-based, peer-based approaches, which can happen in a community setting. So yes, telehealth and specialty care and meaningful access by enforcing mental health parity to health plans. All of that is what needed for meaningful access to mental health care, but we also, based on the social determinants, know that we have to provide access for more than that if, in fact, we're going to have a population-level impact. And I'm not talking about the population of covered lives. I'm talking about everyone.
Yeah, and I think I'm glad you brought up the coverage issue because, you know, mental health care was only really mandated to be covered by health insurance plans with the Affordable Care Act. And even then, some insurance companies are kind of reluctant. How do you propose that we help insurance companies take this more seriously?
Well, I do agree that there had been in the past different sets of benefits for members, dependent on the business model of the health plans. That has changed. 2008 and on, is now requirements by the health plans. Last week, I was out of state at a conference with others of my health plan executives, and it is clear that not only are they serious, but diligently working to ensure that members are getting the care based on the regulatory requirements. But, you know, at Sharp, as you saw, we think that you have to go further. And there's others that are sophisticated health plans that are not just in California, but a lot of them are based in California and across the country. And the idea of providing holistic care for whatever the members' needs are, and too much of the time, the members, it's still stigmatized behavioral health, and therefore we have to push to get that information from the members, but we also have to have our providers ensuring that that information is being discussed while they're in their offices or through telehealth, through whatever modalities would be best. Just one quick point otherwise is that moving away from fee-for-service, I think, is also part of the problem. Because what it does is it helps to silo the care into, well, no, that's medical care. No, that's behavioral health care. Those barriers have to be broken down. You have to have the fullest way to be able to ensure that providers are caring for their members, not caring for a piece of their care, because that's how they get paid.
Yeah. Tyler, do you want to respond to that? I know that you have feelings about health insurance and the role.
Well, Cary's pointing this out. It is the law of the land for the last decade, based on the Mental Health Equity and Parity Act, that health plans need to provide the same quality of packages on mental health that they do on physical health. That's the law of the land.
There's a yeah, but, however.
And there's a yeah, but, because there is a huge spectrum of how well health plans do that. And so you'll see report cards across the country with some health plans failing miserably to meaningfully actually live up to that, and others doing much better. So I think what we're looking at is not only meaningful access to care, but to a continuum of care that includes everything from peer and community supports to specialty care, with everything in between. And that's where telehealth fits, is in between.
I have to agree. So this whole point about parity is great, but there's parity of coverage, and that's where it ends. It's not parity of access, it's not parity of quality care, it's not parity of outcomes in mental health care, and that's a huge failing. So it's great that, I mean, payers have to cover it, that's it, but they don't have to ensure that when you open up the directory and you call one of the providers there, that that person is actually available to you, and it takes 6 weeks, 8 weeks, 3 months, 4 months to find a provider. So we've actually worked really closely with payers to help change that paradigm, pushing to make it make no cost share, no deductible apply for some of the types of care we provide, because cost is still a barrier. Even if it's covered, if you have to pay $10 or $20 out of pocket every time you go visit your therapist, guess what? If that's, you're gonna put that $10 or $20 to your insulin, you're gonna go get your insulin, you're not gonna go see your therapist. It turns out that you need to have done that mental health work as a prerequisite to improve your diabetes, right? So how do we shift the dynamic and reframe the incentive structure so that patients are incentivized to actually have access to high quality care that they need?
I would just add and suggest that payers are concerned about this too, because as much as We want to provide access. The providers are not available for access. There is a limited base of providers, and that's why our idea of expanding into a lot more and different ways that have not truly been access points in the past, that face-to-face may not be the future of behavioral health in terms of it'll be a part of it to provide that portion of the continuum of care, but a certain percentage needs to see their behavioral health providers face-to-face. Others will be able to get that care in different ways, some of which I don't think we fully have vetted out. And I think that there's a lot of incredible companies that are coming out with that version 2.0 and 3.0. Exactly. But I mean, telehealth and the royal telehealth, that is so far beyond what we're looking at telehealth today. Looking at AI as a mechanism to be able to assist patients, I hate to say it, through algorithms and smart ways to be able to identify who needs to be seen face-to-face, who can be seen by somebody via phone, who can use management by digital means. I think we got to look at every source possible for access, because it's not just health plans looking at it in terms of financially, because I think we all agree that financially, if we can get our patients behaviorally health treated, then we can do much more in terms of reducing the total cost of care and improving quality.
And I think we have an opportunity to move the conversation outside of the clinical care business model also, to actually look that community is the source of health and well-being, so that we're looking at community health workers and promotoras and peer-based strategies and recovery communities that are nested in community, that are part of this, not just the things that fit in the economics of big companies.
Right, but how do you balance access to care with quality of care? This is something that we've been talking about off stage.
Yeah, I mean, I could spend the rest of the day talking about this. And this is one of the challenges in mental health care, right, or behavioral health care, is it is still so much of a black box. But at the same time, there's actually a rich, decades-long evidence base of high-quality care delivery models. The problem is that they're either not being put into practice, or we don't have insight into knowing that they're being put into practice. So I think you gotta measure. I mean, both of you guys talked about outcomes and measurement, and the same way we're asked to measure blood pressure or cholesterol, or the percent of your population getting mammograms and colon cancer screening. Okay, let's measure outcomes in mental health and start to put value-based metrics on it, hold providers accountable, make sure they're providing outcomes back to whoever they're held accountable to, and pay them accordingly. I think that's how we got to do it.
Great, yeah. Tyler, one thing I'm wondering is, who needs to lead this charge? Because I know that, like I've said earlier, there's so many different pieces moving. We have so many different people from different sectors. Who should be leading this charge to make mental health more of a focus in the U.S.?
Yes.
Everybody.
I mean, it was a beautiful day last Thursday in the Kennedy Caucus Room on Capitol Hill. All the mental health organizations that have separate Hill days, separate policy strategies are finally coming together around bipartisan federal mental health strategy and state mental health strategy. This is beautiful to see the behavioral health, mental health organizations coming together. After that, there was a meeting of the funders trying to bring more money into the field. So we're seeing that. But all the way from that to kind of, if I may, just you and I and all of us in this room, the thing we share is our suffering. Every one of us knows what it's like to suffer with some level of anxiety or depression or addiction. And if we don't suffer from ourselves, we have somebody who does. And so part of it is, how safe do we make it at school, at work, in our conversations, to have the real conversations of significance. Yeah. To help open that conversation, to help someone get the care they need, to find that, to be able to have that. And that means every single one of us, 330 million Americans, all of us in this country have a role to play in our interpersonal relationships, as well as schoolwork, and in our democracy, for God's sake. Let's get ourselves together to vote, to make sure that people can pay for the care that they need to get.
Yes, what a powerful note to end on. I really appreciate it. Thank you guys so much for being here. I hope you guys enjoyed this discussion as much as I did. Thank you all.